Good morning, everyone. We have immense pleasure in starting this CME, which is a great effort taken by Anirudh sir and urology team. Because of their conceptualization, this CME is happening with a good support from radiology associates. We are having this CME with a good number of delegates.
Good morning, everyone. On behalf of Radiological and Imaging Welfare Association, Aurangabad, in association with Aurangabad Urology Association and Department of Radiology and Urology, MGM Medical College and Hospital, I welcome all of you in the Uroradiology Symposium. Friends, we have started since last few months the dialogue between the clinicians and the radiologists. What clinicians expect from the radiologist, and what a radiologist should report, and what radiologists they want from us, that we are going to discuss. A small request here for all the speakers. This is only this symposium only up to 3:30 am.
Team, because of their conceptualization, this CME is happening. My request will be more on discussions that will be helpful for everyone in day-to-day practice, rather than just talks. So that will be helpful for both radiologists as well as expectations from the urologist, and so that radiologists can improve themselves on some points. Thank you.
Let us start with the first talk by Dr. Anirudh Kulkarni.
Good morning all. We'll start on time. So next 15 to 18 minutes we will be discussing on RGO and SUG. Thank you to most of the clinicians who have been very friendly to me for providing clinical data for over a period of time. Special to mention Dr. Panitkar, Dr. Abhay Mahajan, Dr. Ajay Oswal, Dr. Jiten, and remaining few. The male urethra is consisting of anterior urethra and a posterior urethra, out of which different dimensions and length has been mentioned on the slide. The length is 16 to 22 centimeters, the diameter more or less with distensibility is around 6 to 7 centimeter. Whenever we are considering stricture urethra or a calculus disease, we are evaluating the anterior urethra more or less. For posterior urethra, more or less, we will be doing MCUG in most of the instances. So this is a classical image of the RGU, where we are looking at the posterior urethra, which is consisting of two parts, that is a prostatic urethra and membranous urethra, and the anterior urethra, which is again composing of two parts, bulbar junction and the penile junction or the penile urethra. The causes of the stricture urethra could be trauma, inflammation, iatrogenic. We will not go into much of detail. There can be a stricture, and stricture along with the calculus, it presents with dysuria, poor flow or UTI-like features. The investigations which are needed for it are the other one, but we will be discussing on RGU and sonourethrogram in next 15 to 18 minutes. The surgical options more or less depends on site of the stricture, length of the stricture, complexity of the stricture, presence or absence of skip lesion in terms of different strictures seen in bulbar plus anterior urethra, fibrosis associated which can be diagnosed on SUG. The literature says urethroplasty is of option when the bulbar urethral stricture is more than 2 cm, penile shaft urethral stricture more than 2 cm, presence of a multiple stricture, presence of a repeated stricture, or in cases of traumatic patients, delayed treatment protocol for fracture pelvis. Whenever we go ahead with RGU, there are certain things which are very important, like go ahead with the clinical story, what is there, control QUB, and control QUB along with control ultrasound, because that will give you idea about presence of a calculus disease associated with the stricture. We need to look at the prepucial positions and also consider hypospadias and epispadias, because depending upon that, urethral meatus needs to be sought for and through which the cannulation is done. Asepsis precaution is mandatory. Straightening of anterior urethra, that is stretching of the penile shaft, is very important, because we will be able to look at the stricture in a great detail during the RGU. Dilution of contrast is mandatory. Oblique films and penile direction over the soft tissue is equally important and mandatory. We need always look at the presence or absence of air bubbles, and which can be avoided very easily. The pressure during the we should avoid the air bubbles. We should avoid excessive pressure while putting the contrast into the anterior urethra, so that we can prevent the iatrogenic periurethral leaks. We should look for hematuria. Always better to have antibiotic cover post-procedural, and we always do a comparative ultrasound in combination with the RGU. So this is classical bulbar urethral stricture. At the same time, what you can see is that if the control film is not taken, then probably we'll miss this tiny calculus along with the stricture which is present there. So that's how the importance of the control film is always there. The stricture morphology in terms of RGU should be defined in terms of single stricture, multiple stricture, length of the stricture and extent, crossing the boundaries, caliber, that is the caliber of urethra pre and post stricture, distensibility overall as far as the anterior urethra is concerned, if at all there are any false passages, periurethral leak, and whether the contrast is easily ascending to the posterior urethra and bladder or not. So spongiosa fibrosis, which is key important feature in case of urethroplasty, can be assessed only on sonourethograms. So length of the urethra, as we have seen in first slide, is 16 to 22 centimeter. Diameter is 6 to 7 millimeter in bulbar urethra as well as the anterior urethra. So these are the classical diagnostic features in few of the cases. Here you can see the distensibility is less. The bulbar urethra is absolutely normal. Here you can see there is a navicular fossa area which is seen as a stricture over there. And the contrast studies also will show a segmental stricture involving the bulb, irregular anterior less distensible anterior urethra with the serrated margins, and on cases where post-traumatic, where we want to evaluate a segment of urethra which is missing or completely stricture, we need to take what is called the choke urethrogram. So here you can see that the anterior urethra is well distensible. You can see on MCUG that it is returning to a bulbar junction, but this portion of the urethra is completely missing. That's the reason that's a post-traumatic patient. Now in this patient you can see there is urethral diverticulum which is nicely depicted on anterior urethra as well as posterior urethra, and the sandwich film will always help. Here you can appreciate a tight bulbar urethral stricture, a segmental bulbar urethral stricture, and here there is a tight stricture involving the bulb and a classical BXO in which the entire anterior urethra and the bulbar urethra is less distensible along with the serrated margins, and this patient will have an extensive spongiosa fibrosis. In many individuals where there is a urethroplasty which has been done or the stricture repair has been done, we can do what is called as the tube RGU, where you want to see whether there is any leak apart from the which is seen adjoining to the site of operative nature. This is what the sandwich film really looks like. This is bladder and this portion of the urethra is completely missing. At the same time, in case of fractures, you can depict that this portion of anterior urethra is completely missing, and in the sandwich film you can show that the area of bulbar membranous junction and part of the posterior urethra is also being strictured because of the post-trauma. There are patients in which the buccal ectoderm urethroplasty has been done, and we want to look at the end result of what is happening to the bulbar urethra which has been repaired, and here you can see that the bulbar urethra now is well distensible post urethroplasty. So RGU can be easily done in patients to look at the results of bulbar mucosa urethroplasty. The sonourethography, we can use normal saline as a contrast, you can use ultrasound contrast enhancing agents, or we can use gel. But in my center, usually we use lidocaine hydrochloride gel for that matter in most of the individuals. The same technique that we use particularly while doing RGU is adapted for doing sonourethrogram. Again, we retract the prepuce, we straighten the pelvis in well formation, and then we put a transducer along the posterior aspect of the shaft, and this is the cannula that we use. Now this is how beautifully we can see the anterior penile urethra, where distensibility is quite beautifully seen. At the same we can see the contrast being ascending up into the bulbar region, and distensibility is absolutely normal. So here I can measure very easily the distensibility. Here I can measure in terms of bulbar urethra the distensibility, and if you look at visually also, the ascent of contrast through the anterior urethra as well as bulbar urethra can be beautifully seen in case of normal cine lobes that we encounter. So in case of normal sonourethrogram, by looking at the distensibility of penile urethra and the bulbar urethra, I can definitely make out and say that there is no evidence of stricture in this patient. The issue related with sonarothrography is that it's operator dependent, reproducibility so that the operating surgeon can understand the images as well as cine loop is a area of major concern. On many instances it becomes very shabby because there is a lot of spillage over the area of interest, direct lack of visualization which is indeed required for all operative surgeons, and many patients the skip areas where there is a what you can say associated stricture along with the present stricture which is a major concern can also be missed. Now this image which is consisting of a bulbar urethral stricture is very easy to understand for most of us including the operative surgeon. So this kind of an entire panoramic view looking at the anterior urethra and bulbar urethra is absent in case of sonourethrogram. But the advantage with sonourethrogram is that the spongiosa fibrosis identification is very nicely seen. The stricture involving the bulbar urethra can be depicted better than the RGUs. The length accurately can be measured beyond that, and along with that the diverticulum and the calculi, secondary or primary because of the stricture, also can be seen, and the radiation free study is always to our cater. But we always must should remember that the RGU is gold standard, it is less operator dependent. The learning curve of RGU is far more easier as compared to SUG. The reproducibility in terms of film format is quite easy. The impact over the operating surgeon looking at the image where in one go we can see the anterior urethra is very high with the RGU. But still, why SUG is becoming more popular? Because we can see the site and distribution, we can comment about the length very easily, we can comment about number of the skip lesions on very frequent occasions, and periurethral fibrosis, which is a key component in case of urethroplasty, also can be considered. So this is a nice article which states what is the impact of urethral ultrasonography in case of decision making in case of anterior urethroplasties. There have been attempts in grading the strictures on urethra as far as the SUG is concerned, but if you look at it, it's more or less a grey zone. So it's more subjective in nature rather than any quantification in terms of mild, moderate and severe. But still there have been good attempts all over the world in quantifying the cine loops and the images on SUG. Let us take few examples. Now this calculus which is seen here could easily be missed on plain film, which can be nicely seen on ultrasound while doing SUG. This is a serrated margins of entire anterior urethra along with peribulbar urethral leak over there, which is nicely picked up as a stricture format and a peribulbar urethral leak over here on SUG. Now visually it's very impactful to know that this is a segmental stricture involving the bulb. Now if you look at this static image where the spongiosa fibrosis is there, at the same time on the cine loop you can appreciate a non-distensible segmental involvement of the bulbar urethra very nicely. So comparatively on cine loop it is very easy to understand, and comparatively to RGU we can always give a good dogmatic evidence stating that it's a segmental stricture. Look at this cine loop on a RGU. You can see that there is a complete compartment like a feature where a complete what you can say absence of a contrast seen in this region, which is a tight stricture involving post bulbar region of anterior urethra, and the same thing can be seen very easily and beautifully on the sonourethrogram. So distensibility on either side is absolutely normal. I can see some segmental membrane like a structure intervening between the two structures. At my place, I do RGU and SUG in all of the patients, and whenever I find that RGU has a stricture, I give more significance to the assessment as far as the length, skip lesions and associated spongiosa fibrosis while doing the SUG. Let us take few cases so that it becomes more easy for us to understand. Here you can see a bulbar urethral stricture. Comparatively non-distensible bulbar urethra is very nicely seen along with the spongiosa fibrosis. Here there is a tight bulbar stricture. The intervening membrane or a stricture segment can be seen very nicely. The bulbar urethra is the one which is more looking like a curve. I think the anterior urethra or the penile urethra you must have seen in earlier all cine loops as a straighter component. So here you can see it's a bulbar urethra and very tight stricture segment over there. Now again you can see in the bulbar urethra you can see a tight stricture segment over here, and which is very nicely and equally good appreciated on the cine loop of sonourethrogram. So in the bulbar urethra, the appreciation of stricture segment and spongiosa fibrosis is far superior in all the SUGs that we have seen up till now. Now let us take a segmental stricture involving the bulbar urethra. Now this is a segmental stricture. Now here a comparative statement of the urethra which is well distensible here. The urethra in the remaining portion of the bulb is well distensible here, and on the transverse we can calculate the caliber of the anterior urethra pre and post stricture very easily. So it's quite obvious that the SUG always score over the RGU in depicting the characterization of the stricture segment. Now in this patient you can appreciate that it's a Balanitis uretica obliterans, and here in whatever senior loops up till now we have seen, the distensibility of the entire penile urethra is less as compared to whatever we have seen up till now. At the same time, adjoining the hyperechoic area surrounding the urethral stricture area can be appreciated as a spongiosa fibrosis. So the extent of the stricture as well as spongiosa fibrosis also can be appreciated. Now here you can see later, that is the post-bulbar region of the anterior urethra is serrated. The amount of narrowing is extensive, and the same narrowing and extensive stricture also can be appreciated very well in the senior loop. Again, as I stated earlier, we can always compare area proximal and distal to the stricture segment and assess the caliber on the transfer measurement. On many instances, there can be a primary calculus disease producing the stricture or a vice versa. Here on control film you can appreciate a large calculus over there in the posterior urethra, and on the RGU or the sonourethrogram also you can appreciate that there is a dilatation of the bulbar urethra over here and a calculus which is nicely seen, which is causing pinching of the bulbar urethra in this region. This is a curvilinear appearance of the urethra is the bulbar urethra on the ultrasound. Now henceforth in few of the slides I will show you only sonourethrogram and not the RGU films. But still I think in last 10 minutes whatever we have seen, you can appreciate that this bulbar urethra is harboring one a tight stricture segment which can measure from this part to this part and which can be appreciated by. So basically interpretation of sonourethrogram is only possible when we train ourselves as an imaging person or an operating surgeon. So how we can do better in terms of doing the job is to have a learning curve where we can train ourselves in identifying what is normal distensibility and what is the stricture segment for that matter. Now again I am not showing any RGU film, but still you can make out that this end portion of the anterior urethra is absolutely normal, and this bulbar urethra is showing membranous interruption which is characterized by urethral stricture involving the bulbar urethra. Again, in this patient, there is a comparatively less distensible urethra over here. This urethra is well distensible. Along with that, I can demonstrate a calculus disease and a minimal leak of contrast adjoining to the calculus disease. So probably there is a calculus along with a stricture segment over there along with a periurethral leak. Now in this patient, again you can see in the bulbar urethra, there is a urethral stricture along with a calculus disease. So entire attempt is to tell you that as we train ourselves in identifying the urethral stricture along with the calculus disease and a spongiosa fibrosis, definitely probably in due course of time, at least a combination procedure in terms of RGU plus SUG can gain an importance so that it can have an impactful reference as far as performing the surgeries are concerned. So our area of great concern is a reproducibility. So whatever I feel like a stricture, a person who is operating also should equally feel that we are dealing with a stricture, and this only can be overturned by training ourselves in identifying the senior loops and everything. So what I tried recently is that giving an image where I have given RGU along with a sonourethrogram in a static format. So whether it has got a good impact or not. Now look at this image. This is a bulbar urethra, and I am trying to depict this same image by capturing an image from a senior loop of the sonourethrogram and try to give a comparative statement between the two. Now if we can give similar kind of images in a combination procedure where stricture along with the spongiosa fibrosis on sonourethography can be depicted very easily, then definitely probably in due course of time this combination procedure will have a greater impact on dealing with the all strictures. Now here again you can see, can you see this tight stricture over involving here, and the same stricture again, this course of the bulbar urethra is depicted in a similar fashion on sonourethrogram. So this is the one good attempt. Probably I am trying in recent time, and it is giving good result for me. So crux is that sonography can be used in due course of time as a single tool for guiding for urethroplasty in the future. The learning curve is not that difficult. In combination with the RGU, enhances the efficacy in diagnosing length as well as the skip lesions of the urethral stricture. The operator team needs to train a bit of understanding as far as reproduced finding on RGU and SUG. Thank you very much. I hope you like that 15 minutes. I think it was there. Yes, it was definitely 15 minutes.
Now I request Dr. Baba Saheb Dakni sir to give a brief presentation.
Good morning to all my respected teachers, seniors and my colleagues. Thank you for giving me the opportunity to give a talk on ASU and sonourethrogram. Ascending urethrogram or retrourethrogram, it is actually a radiographic study of urethra using a iodinated contrast media, and it is generally carried out in males. It is commonly done procedure in reconstructive urology for operative planning and as well as the follow-up procedure. It is less invasive than the urethroscopy, and it is gold standard investigation in the evaluation of the stricture urethra. ASU actually it leads to the radiation exposure of 1 to 2 millisievert, equivalent to the 6 months of background radiation and 20 chest X-rays. It has a sensitivity of 91% and specificity of 27%. The positive predictive value is 89% and negative predictive value is 76%. Main indications are the pelvic trauma, diminished urinary streams, urethral stricture, urethral diverticula, urethral obstruction, suspected urethral foreign bodies, and suspected urethral fistulas. The complications are urinary tract infection, urethral trauma, bleeding, and intravasation of the contrast. The limitation of retrourethrogram is it is difficult in assessing the very distal strictures and assessing the proximal extent of the stricture, which are too narrow to permit the passage of the adequate contrast, and it underestimates the length of the proximal bulbar urethral strictures, and also it has a disadvantage of underestimating the periurethral fibrosis. Actually, what is the normal studies? So the normal study must demonstrate the continuous contrast column extending from the fossa navicularis to the urinary bladder, as it is shown here. Then penile urethra should be mostly in uniform caliber, with the bulbous urethra slightly larger than the penile urethra. At the bulbomembranous junction, there should be a smooth change in the caliber of the smaller membranous urethra into a larger bulbous urethra. With adequate distension of urethra, the verumentum is actually seen as a ovoid filling defect in the posterior prostatic urethra. It is seen in the picture of this RUG. What are the problems during the procedure? The patient position is critical. It should be in oblique position to maximize the visualization of the bulbar urethra. The proper positioning can be confirmed by the closed, downward oriented obturator phenomena, and balloon slippage may occur when the pressure from the hand injection displaces the balloon and expels the catheter from the penis. Here it can be seen as an improper position of the RUG. Increased extrinsic sphincter contraction secondary to the spasm may result in the non-opacication of the posterior urethra. Penis should be placed in a stretch in order to maximize the complete assessment of the urethra. Improper penile positioning may result in the distorted urethral anatomy appearance that may mimic the strictures. Here are some pictures which may show where the penis is not in a stretched position, and sometimes we give the extra pressure while injecting the contrast medium. It will result into the intravasation of the contrast medium. Sonourethrogram. Sonourethrogram, first described by the McEnany in 1988. It is a simple, rapid, safe and effective. It is an adjunctive technique in the evaluation of the urethral stricture. In sonourethrogram, the male anterior urethra is examined with the high frequency ultrasound with installing intraurethral normal saline or gel. It is more sensitive in identifying the stricture in the penile urethra compared to the bulbar urethra. It is superior to the retrograde urethrography, and it is highly sensitive and specific investigation, but it cannot evaluate the posterior urethra adequately. The benefit of sonouretrogram, it includes the three-dimensional anatomic assessment of the stricture length and the location. Actually, it is a new, relatively a new technique, but it is underutilized in most centers. What are the advantages of it? It avoids the ionizing radiation, especially to the gonads. It better delineates the intraurethral lesions such as the calculi, granuloma, neoplasm and walls. It may reveal the associated pathologic features in the neighboring structures like penile plaques, neoplasm, vascular and prostatic pathologic process. The information on the presence and extent of spongiofibrosis which helps to determine the therapy. A major drawback with the SUG is its limited ability to evaluate the posterior urethra. Another significant limitation is inter-observer variation is there. In future, sonouretrogram might replace the ascending uretrogram or the retrograde uretrogram as an investigation of choice in the diagnosis of stricture urethra. Thank you.
As a urologist, what I want from the radiologist, because the discussion should be like what should be the position of the penis, what should be dorsiflexion, ventriflexion, supine position, lateral position, what happened in that position if RGU is done, then what are the types of ways of injecting the contrast, the material used, cannulas, feeding tube, Brodnik lamp in olden days, sir may be knowing. So, how it is changed and come to the catheter with 2 to 3 ml of bulb inflation. Then, as far as the both is concerned, there is very minimum role of sonourethrogram in posterior urethra, assessing the posterior urethra stricture. So, the concept of stricture is wherever there is a spongiosa, then only it is called a stricture. So, up to what level it is a spongiosa, so it is up to a membranous. So, membranous urethra is not a stricture, it is stenosis. Bladder neck, stenosis, no bladder neck stricture. So, stricture is distal to the stenosis, membranous urethra. And why there is a straightening? If what happens if not there is not straightening? Visualization of copper glands, then intravasation, extravasation, then nature, site, length, numbers. That's what will matter while planning the management of the stricture. So, this discussion should be there in both of your presentation. As far as sonourethrogram is concerned, yes, there is a role in future in non-transecting urethroplasty. I am doing a non-transecting urethroplasty since last 2 to 3 years, and it is very helpful in that. If you give exactly, there is a spongiofibrosis is limited to only the submucosa, then I will go for, without transection of the urethra, I will go for non-transecting urethroplasty. So, sonourethrogram for assessing the spongiofibrosis, definitely there is a role, and whatever the common benefits of sonourethrogram over RGU is always there, they are not going to change. That's from my side. Thank you.
See that Cineloop on their desktop or on their mobile. If we see that Cineloop, we'll start relying on that investigation more and more.
No, majority radiologist doesn't do a combined study, except sir or few.
Yes.
Okay. So, stricture length can be measured on that X-ray film also. Whatever they taken. If you place the caliper down, or if you measure the inferior pubic rami breadth, it is 2.5 centimeter, and that can be judged with the length of the stricture. So, they can give a length of the stricture also. So, whenever there is a question of spongiofibrosis, yes, there is a role of sonourethrogram.
Exactly. But urologists should train themselves to
Agreed.
see that imaging modality. That
Agreed.
is the only limitation from urology side.
Agreed, sir.
And if we start seeing Cineloops, we'll learn that investigation better.
The role of sonourethrogram is only to assess or to evaluate the prognosis of the stricture patient after treatment. That is the only indication to do a sonourethrogram, because the length of spongiofibrosis which is seen on sonourethrogram, see on ASU, suppose you see a stricture of 2 centimeter, on sonourethrogram it will be always more than 2 centimeter, because the spongiofibrosis which is seen is better on sonography. So you can only predict the prognosis of treatment. Like suppose you are subjecting this patient for visual internal urethrogram. So if the spongiofibrosis is more than say about 2 centimeter, you can tell the patient that probably this stricture is going to recur. If you are going to do a traumatic urethroplasty, end-to-end urethroplasty for traumatic stricture urethra, then you can assess whether this patient will require an inferior pubectomy or you can just avoid an inferior pubectomy. What is the proximal length of the spongiofibrosis on sonourethrogram? So these are the only factors which will assess the prognosis of the stricture after treatment. That is the only indication, or that is the only advantage of sonourethrogram.
See, the spongiosa fibrosis, which is a key component in deciding factor as far as the treatment option is concerned, is far superiorly seen on sonourethrogram, number one.
Agreed.
Number two, the skip lesions, on many instances, associated calculus, primary or secondary because of the stricture, always can be picked up very, very beautifully on the SUGs. And thirdly, I never said during my talk that it's independently is going to gain as equal importance to RGU, but still what I personally believe is that because now more or less most of the urologists, they do themselves few of the ultrasound studies. Now they are capable of understanding what is hypo, what is hyperechoic, which is fibrosis, which is, so eventually I personally believe that if the distensibility is compared pre and post stricture, and the skip lesions and calculus along with the stricture segment also can be identified very easily in due course of time. Now there are centers who do what is called as a contrast enhanced sonourothrograms, where not only the urethral distension is measured, but at the same time a differential spongiosa fibrosis appearances in various part of stricture segment involved also can be assessed. I personally believe that due course of time probably there is a good time as far as the SUGs.
It is definitely complementary to RGU. Only thing is you can mention in your report, if you are doing it regularly, that the stricture segment on RGU is 2 cm, on sonourethrogram it appears more than 2 cm. So that will be helpful for us to manage or treat the strictures. That is one point that you can mention.
Yes, nowadays we can always...
On ultrasonography study, this stricture is definitely longer than what you see on RGO.
Another one more important thing for the radiologist is that they should see whether the patient is under the antibiotic coverage or not. That is very important because most of the, it was standard teaching that a patient, if he is admitted, we used to give a injectable antibiotic single shot and then we used to send the patient for RGO or ASU. But nowadays when patient is on OPD basis, the radiologist should confirm that the patient should not have a infection gross or he should be have under antibiotic coverage. Otherwise we have seen that patient who had undergone RGO and then in evening they come with chills and rigor and urinary problem and dysuria and hematuria or whatever it is. So this is the most important thing radiologist should look for.
This is an important aspect. One more thing I would like to say that before we evaluate the patient, we take them in confidence, we do all the formal procedures and also ask the patient whether you have any drug reaction. Because that is also important. I don't know, I would better understand how much the contrast medium is being absorbed by urethra and urinary bladder.
Especially there is an intervention just before here, like say catheterization. Always ask for history of intervention before the procedure, like say they could have attempted catheterization and that can lead to absorption more often.
No, that is one more thing because I have seen in my clinic since last I am practicing last 49 years and a lot of RGUs and MCU were done during the procedure, my lifestyle. I have seen patients who are having intravasation or extravasation. Those patients do get reaction. So as soon as you have done procedure and if you feel that there is extravasation or intravasation of the dye, you ask the patient to stay there in your clinic for at least half an hour because there is chances that patient may get a delayed reaction.
Especially when there is active urethritis, 1, and 2, if the force of injection is a little more. Intravasation is much more common. And in these, there may be a possibility of a reaction.
Because I have faced with 3 patients, you know.
At
who
least
had-
about 5% of patients need admission after the procedure for antibiotics.
So,
Thank you.
if no questions,
One more thing I would like to say. When we put the catheter and say Foley's catheter plus routine catheter for the RGU, so the most of the meatal portion generally missed sometimes, because you take the film and anterior meatal end is not seen. In that case, what I do is generally is I put the dye into the urethra, I remove the catheter, I just put the prefuse pressure on the prefuse and release it, and then that time I take a shoot. So you get the meatal end very nicely. Thank you.
Thank you.
thank you.
Thank you, sirs. That was a very valuable discussion. And thank you, chairpersons, for moderating the presentation.